Hello everybody, I'm Olof Akre, professor at Molecular Medicine and Surgery, and I'm also a urologist in Department of Pelvic Cancer in Solna and Huddinge. So working mainly clinically with prostate cancer, but nowadays also head of the clinical department. I'm going to give this in English because it's a webcast, and maybe some of you don't speak Swedish either. So if you're wondering why I'm speaking English, that's why. A bit about my background. I studied medicine in the 90s. I'm 48 years old, and I started doing a PhD in epidemiology or cancer epidemiology. I started around when I was halfway through my medical studies in '94, and so I became a doctoral student at Uppsala University, where I did my medical studies, and then I finished both my PhD and my medical studies in '99. So I did a PhD on testicular cancer epidemiology in '99, and I also became a medical doctor that year. So it's 20 years ago, actually. It's scary. Time flies. Then after that I did my residency at St. Görans, no, not residency, but my internship at St. Görans sjukhus in Stockholm, and then I started doing full-time epidemiology, and I was teaching and administering the clinical research school in epidemiology. It's given to clinicians in Stockholm's läns landsting, a 20-week research education course or program. Finally, I ended up in urology, probably because of my PhD in testicular cancer, and so I became a urologist, and here I am 20 years later. Okay, now to the topic. I want to talk to you about evidence-based surgery. Everybody knows about evidence-based medicine, but I think it's important to note that there are specific things with surgery that doesn't fit into evidence-based medicine, and that's what I'm going to focus on here. So how to prove that one surgical technique is better than the other. Evidence-based medicine is, of course, testing medication against each other. In this case, it's surgery, and what is special with surgery. And since I have a background in epidemiology, I was teaching methods for research, for doing studies, for a long time, and then I entered into clinical work and realized that this thing about evidence-based medicine and tried to apply it in surgery. So, as you may know, evidence-based medicine is much about ranking evidence, and there's a sort of rule of thumb when we rank evidence that some studies are more proving evidence of something than others. And the highest proof is if you have a systematic review that includes more than one randomized controlled trial, then you have good evidence to draw conclusions about what treatment to give to the patients. Second best is that you have one randomized controlled trial, and the randomization is, as you know, probably a way to balance risk factors at the baseline of the study. So you do the randomization to make groups equal. If you remove the randomization, you instead have two groups which are maybe comparable but maybe not at baseline because they are not randomized. You call that a cohort study. And if you also remove the time relation between exposure and the outcome, you end up in a case control study, because that's when you pick some cases and then you compare those cases of some kind of outcome with a control, and you look backwards in time retrospectively to understand what were the exposures that led to some being cases and some becoming controls or non-cases. If you also remove the controls, you have just a number of cases. So you're down to the level of saying, okay, we had 7 men with the colds, and we all gave them antibiotics, and all were cured in 3 weeks. So it's a miracle. But as you know, it's not. So they could have been cured anyway. So it's not a strong proof of causation. In the end, we have the expert telling everybody, like, I know best, so I do this and that works very fine for me. So this is evidence-based medicine is dealing with ranking studies and evaluating the evidence in favor of different treatments. So the problem could be that sometimes that evidence-based medicine becomes very conservative. So we tend to stick to the randomized controlled trials, and we say that everything that's not a randomized controlled trial is just nuisance. Let's just skip those studies because we can never know if there is causation or not. A very common point made in the literature, in newspapers, in TV, etc. This is not entirely true, but I'm not going to talk about that so much. But I would say today evidence-based medicine is often just making the question: is there a randomized controlled trial? Then we have evidence. Is there not? We don't have evidence. Okay. In surgery, it's a totally different picture. Now I'm talking about culture. So in surgery, we have very few randomized controlled trials, very few cohort studies, very few case control studies. We have a lot of case series where a surgeon has done 200 surgical procedures, and then he publishes, or she, that I did this and it went really well for my patients. That's it. And then we start operating the same way. Okay? And sometimes even a stronger evidence that an expert says, I tend to do this and it works really fine for me. So in fact, in the surgical context, many times expert opinion is evaluated higher than the evidence. And sometimes we call this eminence-based medicine or eminence-based surgery. Maybe you've heard the term. So you trust in the eminence, not in the evidence. And surgeons tend to say, when you come with evidence of something, I did this fantastic trial, 2,000 patients, randomized, everything was perfect, and I found this, and it will almost always be a he, of course. It would say, well, yeah, you might have evidence, but in my hands, this is a good operation, so I'm not going to listen to your evidence. So, very common situation. Sometimes a bit frustrating, I should say. But it's also important here, and this is going to be my point for the rest of my talk, that in fact it's actually they have something to say, and we should listen to them. But there is a giant canyon between those two views. Here, coming from epidemiology, understanding both sides a bit. I'm going to try to give you this understanding now. And I'm going to give two examples. One about cholecystectomy, taking away the gallbladder. One about prostatectomy, taking away the prostate because of prostate cancer. So in the 19th century, late 1800s, we started taking away the gallbladder. We realized that was beneficial sometimes for stone disease. We did this with this operation, the giant scar. 100 years later, the laparoscopic procedure, where we didn't do as large hole, and we used long surgical instruments and a camera instead, and we called it laparoscopic procedure. The advantages of the laparoscopic procedure on the outside is are very clear, right? I would like to be the person to the right, for sure. Shorter postoperative stay, less pain, shorter convalescence, smaller scars, of course, and fewer complications. On the other hand, there were some suspicion of possible harm, namely worse complications. There is one terrifying complication with gallbladder surgery, and it's that you have a leakage of bile duct from the bile duct, and so that can occur around 1-2% of the cases, and then you can be in the intensive care unit for 3 months and die in the end. So it's very, very sad situation if you end up there. So you have to, if it's more common with this situation with laparoscopic surgery, you should be really careful. Anyway, everybody in the business and all the patients thought that this was really a good idea, so the laparoscopic surgery was really surging quickly. You can see end of 1980s, and it was really taking over. The slides later on, if you like. If this had been a medication, we would have had this long drug discovery period, and then after that we would have phase 1, phase 2, phase 3 trials, and then after marketing, phase 4 trials. And this would have taken decades. This is a very strongly regulated area. Surgery and new surgical techniques is not regulated in almost in any way. So what happens is that somebody discovers that we can do this in another way, probably tries to do the surgery on some kind of animal a few times, and then starts off first in human. He or she publishes the new method on a conference and tells the other people about the good experience. The high volume experts in different large centers in the world adopts and starts doing it, and they start publishing, and once they've done so, they start testifying, and once they've testified, nobody wants to do the randomized controlled trial anymore because it's considered unethical. You wouldn't want to randomize something as harmful as the old treatment because it's old. Okay, so in surgery, you at some point in this development, you reach a point where nobody wants to randomize the patient because they feel it's unethical, because they are so convinced that the new method is good. In cholecystectomy, this was the timeline, 1882, the ethically unjustified to a randomized controlled trial in open versus lap cholecystectomy. And it's also difficult, if not impossible, to conduct. So we move quickly from first in human to establish treatment here without the trial, without the evidence, right? But there were some guys in, I think this was Sheffield, UK, that thought that, hey, we can actually do a randomized controlled trial. So there was 4 surgeons in the early 90s that said, okay, we are 4 surgeons, we're reasonable, we are very good at open. We're reasonably good at lap. So us 4, we will randomize the patient. So they took 200 patients, they randomized between open and lap, and they did so after I have put the patient to anesthesia. So the patient was aware that they put some blood on each dressing, so it looked like there was blood everywhere. And they put the treatment information in an envelope and sent it with the patient to the ward and didn't tell the ward personnel what they had done. Okay, so it was actually technically possible to do. It's not really double-blind study, but it's some kind of single blinding. And this was in 1996, so it was actually 5 years after a lot of people thought it was unethical to do the randomized controlled trial. And so what was the result of this? This is an ugly slide because it's from 1996, but I can tell you there are no difference apart from one thing. There was a difference in the operating time with 15 minutes longer with laparoscopy. No difference in the pain, in the hospital stay, etc. Okay, so it's not a success for laparoscopy. And then the important question about harm. That question couldn't be answered. It was 100 patients in one arm and 100 in the other. The frequency of serious complications is 1 to 2%. It's impossible to answer this question in a randomized controlled trial because it's always going to be too small. So they had just a few complications and it seemed to be equal, but nobody knows really. Okay. So Richard Horton, who was the editor of the Lancet at that time, he was really upset, saying, hey surgeons, you have to pull your act together and start doing evidence-based surgery. So the title was Surgical Research or Comic Opera, Questions but Few Answers. He was published in the same issue that this study was published in. So he thought really that this is embarrassing for surgeons. But we have to make a few questions. about this. Did we stop doing laparoscopic cholecystectomies? Absolutely not. It's the totally dominating method today. We had bought the machines at that time, so nobody wanted to stop because they were expensive machines, so let's go on. Yeah. Patients liked it because of the scars, mainly probably because that's what patients care about, as long as they don't get the bad complication. And surgeons liked it. It was fun. It's like gaming. So it's nice. And even if there were some evidence saying that it was equal results, all the laparoscopic surgeons were saying, well, no, in my hands, laparoscopy is very good, so it's much better. Okay, so we are there in the eminence-based surgery. But then I think also we should ask, should we have stopped? And I think the answer is probably no, but I mean, I'm not sure, but I feel no. Because nowadays we know quite well that the frequency of the bad complications have dropped really with the laparoscopic method. We also started cholecystectomies, but nowadays we do a lot of different operations where the patient have a lot of benefit from the laparoscopy. So this was sort of the first step into minimal invasive surgery, which was a really good thing to do for example, kidney cancer, where we do this kind of operation, and instead you do a few holes here and you bring out the kidney very safely with a short post-operative stay, much shorter. Finally, I want to ask, this was a randomized controlled trial for sure, but did we really, could we really say that this study proved that there was you take the two study groups and you compare them on basis of the distribution of different risk factors. This is what these guys did. So they checked is male-female proportion, the grade of ASA grade, ages, BMI, employed, self-employed, kind of education level, sedentary lifestyle, etc., etc. So, in summary, the groups look similar. But the thing is that the surgeons, we did randomize the patient to different surgery, but and what is reasonable experience? Well, in this case, they stated that reasonable experience is that you have either did as a main surgeon or assisting surgeon at least 40 procedures. And I can say that 40 procedures, I wouldn't say that you are very sort of technically skilled after 40 as assistant and main operator. So, and I can assure you also that these surgeons had probably done thousands of open cholecystectomies. So even if the arms look similar with respect to randomization, the arms are not similar with respect to the exposure, which is the surgery, because the surgeons are different. Even if they are the same people, they have different skills in different arms. Okay? So that was cholecystectomy. Same topic, different cancer, different operation. So we moved to prostatectomy. Now we're into robotic, robot-assisted. The operation for prostate cancer was an open prostatectomy. So you do the hole below the umbilicus, and you look as far down as you can into the pelvis, and you have long instruments, and you find the prostate down there, and and it's a technically difficult operation, I should say. In 2001, the robot, the Da Vinci robot came and made this a lot more simple easy for the surgeon. Not simple, but easy, less complicated. So you put all these arms and you connect this robot to these three metallic arms, and you have an assistant helping out. And then the main surgeon is sitting here in the console, working in the binocular. And this is what it looks inside the binocular, just to give you a feeling of how it works. So this is in the pelvis, and this is the we are grasping the peritoneum, and we're now cutting through the peritoneum, finding the vas deferens on both sides, and as you can see, the robotic surgeon can move really, really close to the operator when you're taking out the prostate. It's like a spaghetti, so it's not a big structure, but you can magnify it 10 times in here and work very, very carefully. And why should we work carefully? I'm going to tell you soon, but surgeons loved this. It was an expensive toy, even more gaming situation for the surgeon, so it was very popular. One of these machines cost 20 million Swedish kronor, and then there's a service, so the service maintenance is like 2 million kronor per year. So it has to be better to be worth it for at least for the taxpayers or the insurance payers. Anyway, RARP, robot-assisted radical prostatectomy, the black part grow in the US, and the gray part, the open version, is diminishing over the early 2000, the first 10 years. So why should we have very good technical control when we do prostatectomy? Well, the problem is that you can always remove the prostate with radicality, so to take out the tumor. But if you do it very radically, you're going to remove the nerves that are maintaining functions, mainly continence and sexual function, erectile function, and these are the nerves, and this is the prostate that is cut in the middle, and as you can see here, the tumor is right here, and that's the most common placement of the prostate cancer, is right beside the nerves. So if you cut out the tumor with margin, you also cut out the nerves, and you lose continence and erectile function. So the idea with the robot was that if you have a robot and you have a good technical control, you can take the perfect margin here and reduce the consequences for the patient. So you can have both radicality, radical removal of tumor, and preserving of functions. This was a very big discussions. You could see point and counterpoint debates in all conferences all around Europe and US, mainly at that time, saying that one is better than the other, and the other was disagreeing, and nobody knew what was going on. This is a big Swedish study called LAPRO study, 2,500 men, where it's not a randomized controlled trial. So we tried out those who happened to go through robotic surgery with those who happened to go through open surgery, mainly because where they lived in Sweden, because some hospitals had robots and some hadn't. So it's kind of random. The main endpoints was, of course, so non-radical removal of cancer and quality of life in terms of continence and erectile function. The quick story is that the main outcome of this was that they didn't find any difference. No difference, robot versus open. Okay, so I'm going to skip. This is summing up those results. You can see that the relative risks are around 1 all the way, but there was some difference to the benefit of the robot with better erectile function after robotic surgery. But it's a very weak thing if you're going to pay 20 million kronor and 2 million maintenance per year to do this. And then came also now, quite recently actually, just a few years ago, a randomized controlled trial. So you should note that this was published in European Urology, good paper, good journal, but Lancet is much stronger, right? I mean, then even your mom will know that you have succeeded because you end up in the newspapers. Okay, so because it was randomized, and it was 326 men randomized 1-to-1, one surgeon in one arm and one surgeon in the other arm. Primary endpoint, functional outcome. No difference between the groups. I'm going fast here because I'm just summing up. There were no difference. Randomized controlled trial, So again, bad situation for the new technique. But the guy who was doing the open surgery had done 1,500 surgeries, and the guy in the robotic arm had done 200 procedures in robot. Okay, so you realize what I'm saying? Randomized controlled trial, very nice balanced groups, 326, very narrow confidence intervals, everything looks neat. It's just that it's not a randomization of the exposure, it's just a randomization of the baseline risk. Again, it's very difficult to differentiate the skill of the surgeon from the technique advantages. Okay? And in fact, in the LAPRO study that was just recently mentioned, it was not a randomized controlled trial. In the open arm, there was one super high volume, very well-known surgeon, Jonas Hugosson, who had done 40% of all the procedures in the open arm. So, whereas there were much more beginners in the robotic arm. So in a way you could say, so they are similar, but in a way that's good for robot, because you can be as good as a super expert in a robot through the technique. Maybe. Well, so this is what I'm talking about. This is sort of a measurement of skill. So in a prostatectomy, this is the result of potency, of erectile function in the patients by surgeon. And so on the x-axis you have the percentage of probability of potency at 24 months after surgery, and there's these are individual surgeons, and these are their performance, and so one is open and one is robotic technique. It doesn't matter which is what, but as you can see, this technique and that technique, it's difficult to say that one is better than the other, but it's very easy to see that there are quite dramatic difference within the techniques with respect to the different surgeons. I mean, who would you want to be operated by? The one that has a 70% potency at 24 months or 20? It's the same for continence and the same for radicality. So, but the thing is that sometimes, I'm soon done, sometimes you want radicality and sometimes you want function, because if you have a very bad tumor, you want radicality, and you don't give a damn about the function. And sometimes you have very quite non-malignant tumors, and then you want to prioritize function. So in the LAPRO study, we actually did a stratified analysis by risk of by risk type of the risk category of the tumor, finding that even if in the complete data the radicality looked exactly similar, 20% virtually in both arms, if you were in the open arm, the radical traditional, there were much more positive surgical margins if you had a high-risk tumor, whereas in the robotic arm there was much more low prevalence of non-radicality in the low risk, which is what you want. You want this right part. You really don't want this. So in fact, the robotic surgery managed to disentangle between the ugly tumor and the less ugly tumor, and this also translated into a difference in the recurrence of the disease at 24 months after surgery. So recurrence was more common in the open arm than in the robotic arm, and we also saw similar differences with respect to function. So conclusions regarding robotic surgery, that the advantage of the robotic method is that it's may be better to control the surgical plane and choose when you have to be radical and when you have to preserve function. But when you looked at them as a whole, they looked exactly similar because it cancelled out. And finally, when you evaluate innovation in surgery, new techniques, it's difficult to separate the handicraft from the craftsman. Randomization is not enough. You can't just rely on a randomized controlled trial when you check surgery. Sometimes an observational study with better control of the surgical factor is better than a randomized controlled trial, and everybody has to accept that when we evaluate the evidence. what you have to do is that you have to understand what's really my hypothesis when I'm going to evaluate this technique. What is the robot about? What is actually the potential of the robot? And I had to measure that potential and compare with the traditional method, which we did when we stratified by high risk and low risk. So I think getting back to Grand Canyon and evidence-based medicine and evidence-based surgery, there are both have points in their reasoning, but they are living in totally different worlds. And bridging the gap, I think, can only be done by understanding the principles of what is evidence and what is actually my hypothesis every time I'm searching for the evidence. So I think the guys on the evidence-based medicine side has to understand that if my hypothesis is about surgery, then maybe I need to check if the randomized method is the best. And on the other side, for sure, there is something to learn about randomization, because that's done way too little. Thank you for listening. Thank you.